first segment of this video begins with fetal sexing. Fetal structures are easy to recognize on the ultrasound monitor, which will help orient the ultrasonographer for future topics. To perform an ultrasonic fetal sexing procedure, one must have an understanding of the genital anatomy of both male and female feti. Here we have a 65-day female conceptus with the entire placenta intact. Notice the labeled structures, the cotyledons, the amniotic vesicle, and most importantly, the female genital tubercle. The female genital tubercle, or GT, is located just under the tail in this lateral position. Notice the GT's white and protruding appearance. Fortunately, it shows up in a similar fashion on the ultrasound monitor. The placenta and associated fetal membranes have been removed, except for the umbilicus, in order to get a clearer view of the female GT. In this view, the blue arrow on the right points to the female sex bud. Just as important, the left arrow shows the absence of a penis in the area just caudal to the umbilicus. This frontal view of the fetus is important for several reasons. It is a position frequently seen during an ultrasound exam. It shows the absence of a penis, early developing teats, which at 65 days are not yet discernible on an ultrasound, and the bright female GT superimposed over the tail. This dorso-ventral view is an example of how the tail can cover the female GT, thus creating a false negative image. By rotating the transducer slightly to one side, the tubercle can easily be seen. An ultrasound transducer emits sound waves that are bounced off tissue according to the tissue's density. The same transducer contains receptors that receive the incoming echoes, which are then converted electronically into visible images on the monitor. Some tissues produce strong echoes which show up bright or white on the monitor. Examples would be skeletal structures and, most fortunately, sex buds, both male and female. Other tissues produce little or no echoes, and the resulting image is black on the monitor. Examples would be fluids such as urine, blood, and amniotic fluid. Soft tissue structures would show various shades of gray, such as muscle or visceral organs. This is an 85-day female in lateral view. Take notice of the dome-shaped head. The head is easily recognized and is an important landmark relative to orientation of the fetus during an ultrasound exam. Notice the rectum between the tail and the vulva. Fortunately, the density of the rectal tissue is not highly echogenic and therefore does not pose as a diagnostic threat to the ultrasonographer. Observe the well-developed teats as well as the lack of a penis in the area caudal to the umbilicus. This PA view is very commonly seen during an ultrasound exam. The elongated and well-developed teats of the female are an aid in sex diagnosis. However, it would be ill-advised to make a diagnosis of female based on the observation of teats alone. This 90-day male fetus in lateral recumbency shows the already developing preputial area just behind the umbilicus. The dome shape of the cranium again is an important landmark for anatomical reference. Note the lack of a genital bud under the tail. An ultrasonographer should consider that only as supportive evidence in fetal sex determination. The scrotum appears as soft tissue to the ultrasonographer. Although it is not as highly echogenic as the penis, the scrotum is definitely a discernible structure and an important one when determining gender. This is an ultrasound image of a 70-day male fetus. The image is currently a still frame for the convenience of orientation and labeling. You are looking at a frontal or ventral dorsal view with the head to the right side of the TV monitor. RL is rear legs, UMB is umbilicus, MGT is male genital tubercle, FL is front legs. Again, we are looking at a belly view of this fetus. Its back is toward the back of the TV monitor, and its legs are pointing at the viewer. Moving into real time, notice that the umbilical cord is a major reference point. It is easily recognized either in cross-section or longitudinal view and is always an orientation aid. Always check for a penis just caudal to the umbilical attachment to the abdomen. Although the presence of a male genital tubercle is diagnostic of a male, the absence of a male tubercle does not in itself guarantee a female. The ultrasonographer must visualize either a male or a female genital tubercle to accurately diagnose sex. The other two most beneficial orientation aids are the head and the beating heart of the fetus found in the thorax. Note the labeled structures with particular emphasis on the umbilicus and just caudal to it, the bilobed male genital tubercle. This is a 70-day male fetus in the same position as the previous ultrasound frame. This is a real-time cross-section view of the same 70-day male. Note the male genital tubercle as the transducer passes back and forth through the abdomen, near where the umbilicus attaches to it. Notice the beating heart in the thorax. The scrotum at 70 days in a frontal view appears as a trilobe structure between the rear thighs labeled RT. Make note that the tail is a monolobed structure. RL is rear legs. MGT is male genital tubercle. This is a lateral view of a 95-day male fetus. His head is to the left and his legs are pointed upwards. The entire length of the penis is easily visible. Make note of the umbilicus and follow it all the way to its attachment to the abdomen, and then see the penis. Moving to the rear of the fetus, we get a posterior-anterior view between the back legs and get a perfect view of the now fully developed scrotum. RT is rear thighs. The next few seconds show the entire fetus from head to rear in cross-section, starting at the cranium, going through the thoracic cavity, through the abdomen, noting the umbilicus, then the MGT. This frontal view shows several important recognizable features. FS is front shoulders. Note the close proximity of the MGT to the umbilicus. Notice how less bright or less echogenic the umbilicus is compared to the highly echogenic MGT. The transducer is moving back and forth from the umbilicus to the male GT. Compare the size of the 81-day to the previous 75-day fetus. It is important to understand how quickly the fetus grows from one week to the next. It sometimes is difficult to get proper orientation after 85 days of pregnancy due to the relative size of the fetus. The umbilical cord is a valuable aid in helping to locate the male GT. is right rear leg. LRL is left rear leg. By 80 days, the scrotum is fully visible. AV is amniotic vesicle. Real-time ultrasound produces black, gray, and white images on a video monitor similar to an X-ray image, only in motion. Sound waves are bounced off tissues according to their density. Example, skeletal structures are highly echogenic, which show up white on the monitor, and fluids are non-echogenic. They show up black on the monitor. Fortunately, both male and female fetal sex buds are highly echogenic and appear as white objects on the monitor. The blue highlighted area shows the male GT. By 85 days, it often appears trilobed. By orienting the umbilical attachment to the abdomen, the presence or absence of a male GT can be determined. Compare the blue highlighted male GT of the ultrasound to that of an actual fetus. The subject is now a female fetus. The umbilicus is highlighted blue. The yellow line represents the edge of the amniotic vesicle. Moving to real time, look closely at the point of attachment of the umbilicus to the abdomen. Notice the lack of a male GT or penis. This actual 75-day female fetus is fixed in the same position as the previous ultrasound view. The umbilical cord is highlighted for reference purposes. As the transducer moves distally from the umbilicus towards the tail, note the lack of a male GT. Nearing the tail end of the fetus, look for a bilobe female GT. In this frozen image, the bilobe female GT is highlighted green. A cross-section of the tail is highlighted red. This actual female fetus is positioned like the previous ultrasound frozen image. The yellow highlighted area represents the female GT. This fetus is in lateral position with the head to the left and nose pointing upwards. The cranium is an important landmark and relatively easy to recognize. Moving caudally to the thorax, the beating heart is another important reference point. The fetus is now on its back, giving the viewer a frontal view. The umbilicus is the reference organ and is highlighted blue. The yellow area represents the rear thighs, and the blue structure is a cross-section view of the right front leg. This actual fetus is positioned and highlighted similarly to the previous still frame. Going to real time, look for the presence or absence of a male GT just distal to the umbilical attachment to the abdomen. In this case, there is no genital tubercle present. We can say this fetus is not a male, but cannot say that it is a female until the female GT is located. The transducer must be manipulated so that the perineal area is isolated in a position suitable for evaluating the presence or absence of a genital tubercle. In this still frame, the highly echogenic bilobe female GT is easily seen. This 80-day female fetus is presented in frontal view with head to right. Note the very active heartbeat in the thorax. This still frame catches the umbilicus in cross-section and clearly delineates all four teats of the developing mammary system. The tip of a cross-sectional view of the tail is highlighted in red. At 80 days, the teats are easily recognizable. Also pay attention to the lack of any male reproductive organ around the umbilical area. This male fetus in frontal view is presented for comparison. Look at the male genital tubercle just caudal to the umbilical cord. The male GT is highlighted in red. There are two important features to note in this still frame. There is no penis, and the teats are protruding and well developed. Two major points have been established. There appears to be no male GT, and the teats are well developed. However, a female GT has not been observed, and it must be, in order to positively diagnose a female. This still frame clearly shows a distinct non-echogenic delineation between the base of the tail and the female GT. The tail is yellow and the GT is blue. As the umbilicus comes into focus at 10 o'clock, follow its attachment to the abdomen and note the lack of a sex bud in this area. There is no tubercle, caudal to the umbilical attachment. As the transducer moves slowly to the rear, the female GT is isolated. The red highlighted area shows the female GT. It appears trilobed in this view. The ultrasonographer will have more difficulty getting a good view of the female GT as compared to the male, due to the anatomical location of the female GT. Consequently, it usually takes longer to sex a female fetus, simply due to manipulating the transducer to get a good view of the perineal area. This freeze frame shows the hyperechogenic female GT superimposed through the tail. The blue highlighted structure is the female GT. The slightly less echogenic structure to its upper right is the tail head. Notice the lack of MLGT as the transducer passes back and forth through the abdomen at the level of the umbilical attachment. This view is extremely important to the ultrasonographer. Sometimes the tip of the tail, which is highlighted in red, can create a false impression of MLGT on a female fetus. The tail of a developing fetus is very thin and soft, and it moves in a whip-like fashion, especially at its tip. Because ultrasound works in real time, and because the tip of the tail is moving quicker than the eye, a wider than actual image of the tail tip is seen on the monitor. When the tail is tucked between the hind legs, its tip can approach the area just caudal to the umbilicus and give the impression of a bi- or trilobed MLGT, as depicted in this footage. The blue highlighted echogenic structure is actually the tip of the tail and not a MLGT. This is the same sequence again without freeze frame interruptions. Focus on the tip of the tail and understand how it could be confused as being a MLGT, especially as it hangs between the back legs. This is a PA view with the rear legs pointing at 3 o'clock. The freeze frame shows the perineal area having two distinct hyperechogenic structures. The bilobe structure on the right, highlighted in red, is the female GT. The structure to its left is a cross-section of the tail. Again, the distinct bilobe blue highlighted structure is the female GT. Closely follow the tail in this sequence to delineate it from the female GT. This is the uterus of a mature cow in standing estrus. The red lines outline the border of the uterine horns. The blue represents estral fluid in the uterine lumen. During diestrus, this non-echogenic uterine lumen is usually not visible due to a lack of intraluminal fluid. When a cow is in estrus, it is normal to find pockets of luminal fluid in the region of the greater curvature, which shows up as black non-echogenic areas. The red color here highlights such an area. The myometrium of an estral cow is more thickened than when in diestrus. The transducer is now fixed on one of the ovaries. Follicular fluid is non-echogenic, and this cow in standing heat has a 17 millimeter mature follicle. The entire ovary is outlined in yellow. The follicle is black. The transducer is now fixed on the uterus of a cow 12 hours post-standing heat. The blue highlighted area covers only the uterus. The active ovary has a large ovulatory follicle along with several 2 and 3 millimeter follicles on its opposite border. The green line encircles the entire ovary. The red dots are superimposed over the small follicles. The examination of an ovary of a cow 7 days post-estrus. The entire ovary is encircled by green. The red line circles the corpus luteum with its papillum-colored solid red. Notice the 3 millimeter black dot in the center of the CL. This is not a small follicle, but instead is the fluid center of the CL. This is perfectly normal. As we move on to 10 days post-estrus, the corpus luteum has completely luteinized and a non-echogenic center is not visible. The white line surrounds only the corpus luteum. Several follicles are present to the left of the CL. This is a different cow, also 10 days post-estrus. The entire ovary is represented by luteal tissue. Some CLs will not completely luteinize and will retain the fluid-filled non-echogenic center. This is physiologically normal and is seen at least half of all CLs examined. This view shows a split screen with both ovaries in view at the same time. This cow is in diestrus. The left ovary has 2 CLs, both fluid-filled. The right ovary has a large 18 millimeter dominant follicle. This cow is 11 days post-standing estrus. She exhibits a normal fluid-filled corpus luteum. The fluid-filled center takes up almost 1/2 of the diameter of the CL. This is another day 11 cow. Notice how small and flat the ovary is compared to the active right ovary. The left ovary is very inactive due to the lack of any observable follicles or luteal tissue. The right ovary has a nice fluid-filled CL and a few small follicles. This split screen shows the uterus of a diestrus cow on the left. Notice the lack of a non-echogenic lumen, which is normal in a diestrus uterus. The active ovary has a very large fluid-filled CL and some small non-echogenic follicles. The green structure on the right half of the screen represents the papillum of the CL. The yellow is the fluid-filled portion of the normal CL. The white line outlines the homogeneous CL. The blue line outlines the entire ovary. These ovaries on the split screen appear very large. Up until now, a 5 MHz transducer has been used for this video. However, this image is produced with a 7.5 MHz transducer, which appears to enlarge the image. The 7.5 transducer will give a slightly more resolved image, but at the expense of losing penetrating depth. The white line represents the borders of both ovaries. The red area on the left is superimposed over the luteal tissue. This is another exam using the 7.5 MHz transducer. Notice how large the small follicles appear on the left ovary. The right ovary appears huge along with its CL. This view shows a uterus during the diestrous phase of the cycle. It clearly shows no visible lumen, which is normal during this phase. The uterus is highlighted blue, and the full bladder is yellow. The bladder must not be mistaken for pregnancy fluids. Morphologically, a follicle cyst is differentiated from a luteal cyst by examining its outer wall. A follicle cyst has little or no luteal tissue, whereas a luteal cyst will have a discernible outer rim of luteal tissue. This cyst would be classified as follicular. Another small follicle cyst is forming in this ovary at 2 o'clock. Frequently, one or more cysts will be seen on a cow at one time. This is a luteal cyst as evidenced by the thickened band of homogeneous luteal tissue surrounding the fluid-filled cavity. Green color highlights the luteal tissue. This follicular cyst is beginning to luteinize on its perimeter. Notice the echogenic structures inside the fluid portion of the cyst. This ovary had been diagnosed with a luteal cyst. The cow had been treated with chorionic gonadotropin, and this video was run 8 days after treatment. The red band represents the original luteal tissue before treatment. The inside solid blue color is the luteinization following the treatment with chorionic gonadotropin. This large luteal cyst will be manually ruptured, as you will observe in a few moments. Sometimes it is important to know how well a donor has responded to supraovulatory treatment. In cases where rare or expensive semen is to be used, the ultrasonographer can diagnose if a donor has responded too poorly to use valuable semen. In the case of understimulation, only a few follicles will be seen. However, just because a superovulated donor in standing estrus has multiple follicles does not mean they will all ovulate. This donor seems to have a good response to FSH. The ovaries are outlined in green, the follicles are red. Seven days later, on collection day, the ovaries have responded typically by having some unovulated follicles, some completely luteinized CLs, and some fluid-filled CLs. The CLs are outlined in blue. This is another superovulated donor in standing estrus. She seems to have responded well to FSH, as depicted by the numerous non-echogenic follicles. This is the same donor 7 days later on the day of collection. It is very difficult to count CLs when there is a heavy response to superovulation. 24 embryos were recovered from this donor. Early pregnancy diagnosis can be very helpful for recipient or AI cow management. Although too early to diagnose sex, it is important to know if the fetus is healthy. This 40-day pregnancy has a viable fetus proven by the beating heart. Note the non-echogenic fetal fluids surrounding the fetus. The red color is superimposed over the uterus. Green covers the fetus. At 35 days, the fetus is smaller but still has a discernible heartbeat. The volume of pregnancy fluids is obviously lower. A 30-day embryo has a detectable heartbeat. The fluid volume is noticeably less. The 23-day-old embryo is sometimes difficult to pick up with ultrasound. Pregnancy is diagnosed at this stage on presence of amniotic fluid alone. The yellow represents amniotic fluid. The red line outlines the uterus. Positioning the uterus via rectal palpation is helpful, so the transducer systematically scans the entire uterus. However, one must use caution and not be overzealous in doing so, or embryonic death may occur. It is advisable to wait until day 27 of pregnancy before making a diagnosis of open, due to the variation in volume of pregnancy fluids from cow to cow and apparent differences in embryonic developmental rates. This is an illustration of an actual flushing procedure. The blackened area represents saline entering and exiting the uterus. The echogenic specks in the saline is endometrial tissue. Observe closely the echogenic exudate in this uterus. Its echogenicity is very similar to the uterus itself, but can be distinguished by its glittering-like movement inside the uterine lumen. Echogenic fluid is usually pathological. This fluid was a chocolate-colored exudate when recovered by a therapeutic flush. The exudate was palpable, but ultrasound enabled the practitioner to diagnose it as abnormal. In the case of free-Morton twins, it may be desirable to eliminate them. In any case, it is important to know that a cow will have twins, so that appropriate management efforts can be in place at or near calving. The first fetus is a male, and the second is female, although unfortunately, the female in this sequence does not show up well. Oftentimes, both twins are not visible simultaneously. Therefore, a thorough exam of the uterus is necessary. Occasionally, triplets are diagnosed by ultrasound. All three of these have a healthy heartbeat. They were the result of a donor cow not being flushed, based on the ET practitioner palpating only one corpus luteum on flush day. When the chorionic membrane has separated from the uterine wall, the growing embryo or fetus cannot survive. Notice how the fetal membranes have pulled away from the uterus and are free floating in the uterine fluids. The fetus itself is formless in this example. but it should always be examined for a normal heartbeat, as the circulatory system is usually the first ultrasonically observable system to fail in early embryonic death. To be as complete as possible with this video, transvaginal oocyte recovery has been included. A convex linear transducer is utilized for this procedure, giving a flashlight-like appearance to the ultrasound background image on the monitor. A superovulated cow in standing estrus is used for the model. A 50 centimeter long 18-gauge needle is inserted through the vaginal wall into the follicle of the ovary. A yellow line is superimposed over the needle itself. The ovary is encircled by the red line. Green represents the follicle that the tip of the needle is in. Suction is employed when the needle is inserted into the follicle to remove the follicle contents. The ovary is manipulated so that the follicle comes into alignment with the needle. The needle is then pushed in and out to correspond to the depth of the follicle in question. As soon as the needle penetrates a follicle, its contents are aspirated immediately.
Okay, one of the most important things that we will discuss here as far as using the ultrasound is how to handle the transducer. The transducer tip is very sensitive to any type of a bump or drop. These little, along the sound producing ridge here, there's pixels and crystals in there that can be broken and damage the resulting resolution of the unit. So you want to be very careful in handling this. As far as how we position this in my hand to go in the rectum of the cow, I'll get a little closer and show how I hold the unit. I'm a right-handed transducer holder, and I normally put the back ridge of the transducer along my index finger, and I use my index finger as a guide to go into the rectum. And I almost use my other hand, the other part of my thumb and fingers, to funnel or cup the unit within my hand. And this is the way I hold going into the cow. As I get into the cow, I continue to use my index finger as a guide, again along the back ridge of the transducer. Now some tips on holding the transducer on doing a fetal sexing procedure. I've found that to get the fetus in position is the most critical portion in doing fetal sexing, obviously, other than knowing how to read the monitor and know what you're looking for. But as far as getting that image, that is what requires a tremendous amount of practice and quite a lot of knowledge on how to approach your subject. Now we have a water bag here, a plastic water bag that will assimilate about a 65-day pregnancy. First, I go into the rectum again with my transducer along the index finger, and once I go into the rectum and get into the tract, I like to go down under the tract if I can. And if I get under the tract, just by gravity, the fetus is in position, is going to fall down to the probe. And we actually want the fetus itself as close to the transducer as possible, preferably within 1 to 1.5 inches of the transducer. because the resolving area or the focal area is greatest at that depth. So instead of coming up here and trying to emit sound waves all the way through the fluids of the pregnancy, I like to go down under, and me being right-handed, I wind up having the probe or the transducer pointed to the upper left hip of the cow, to the upper left tubercocci, almost pointed in that direction. And then I do my left and right, or forward and backwards, to get the exact positioning that I wanted. And oftentimes I will put pressure upward into the gravid uterus, trying to get a little closer to the fetus. And I've found that to be a very helpful tip, is to put pressure upward toward the pregnancy, so as to flatten out the gravid uterus to get closer to the fetus. Sometimes that position doesn't work, and I'll come in from the side and put pressure, or I'll come over the top and put pressure back toward me, and that helps flatten. Anything to help flatten out the gravid uterus to get closer to the fetus itself is very helpful. Just as in palpation, one must get the uterus in position to do an adequate ultrasound exam, either for early pregnancy or for fetal sexing or for ovarian diagnostics.